So today's topic is surgical procedure in cardiology. The different disease like valvular heart disease, MS, MR, AS, AR, or myocardial infarction, acute MI, or there is a chronic heart disease landing in different type of cardiomyopathy. There are several diseases that have a surgical procedure in the form of valvuloplasty, valvotomy, coronary arterial intervention in the revascularization, CAVG or PCI, then cardiac transplantation. So cardiovascular intervention have evolved considerably with the advancement in medical and surgical technologies. Valvuloplasty, there is repair. Valvotomy, coronary revascularization, cardiac transplantation is repair and crucial life-saving procedure, have different indications. So, an indication for valvuloplasty means the percutaneous or there is surgical procedure aimed at relieving the stenosis or the dysfunction of heart valve without replacement. There is only repair. One of these balloon mitral valvuloplasty, usually indicated in the mitral stenosis. When mitral stenosis have a valve area is less than 1.5 or there is a tight MS. The favorable valve morphology, a Wilkinson score less than 8. There is a chart, there is a different parameters. No or mild mitral regurgitation, absence of left atrial enlargement and thrombosis, asymptomatic patient with very severe mitral stenosis, pulmonary arterial hypertension, mild to moderate to severe. So what we know in the severe symptomatic rheumatic mitral stenosis or asymptomatic patients that have a severe stenosis with pulmonary arterial hypertension or PAH, what if there is a no MR, mitral regurgitation, or there is a left atrial enlargement is a mild, or there is a no thrombus, is have a favorable conditions for doing the balloon mitral valvuloplasty. So balloon aortic valvuloplasty is like this in the aortic valve. In the critically ill patients, it is a bridge therapy before going to the replacement of the aortic valve. And there is severe symptomatic patient of the AS who have not candidate for immediate valve replacement because due to some other condition like patient may have a heart failure or there is some arrhythmias or there is some infective conditions. So in that condition, so bridging before the going to the replacement. Palliative therapy in the patient with severe AS who are not suitable for surgical intervention or use in a younger patient with a congenital type of the aortic stenosis because replacement have a limited life. So before that we can go for the valvuloplasty. Like this in the pulmonary valve, isolated pulmonary valve stenosis, that is a very rare. P gradient should be more than 50 and symptomatic patient who have a mild to moderate stenosis. Tricuspid, that is very rare. Now comes to indication for the valvotomy. It is typically surgical incision into a stenotic valve to relieve obstruction only. So indication for valvotomy is for the stenotic lesions, whether it's a mitral stenosis or the aortic stenosis, usually indicated in the mitral type stenosis, either open or closed. This symptomatic severe rheumatic mitral stenosis when balloon valvuloplasty is not feasible, patient is in ICU, and some other condition patient is a severe heart failure also. So in that condition, valvotomy is the only choice. Like this, in the presence of atrial thrombus is there, valvuloplasty is contraindicated. In that condition also we can go for the incision in the stenotic valve. Moderate MR is present, that again is the contraindication for the valvuloplasty. So in these conditions only we use valvotomy. Aortic valvotomy, that is a critical congenital aortic stenosis in neonates and infants only. pulmonary, it's indicated in the surgical settings when valvuloplasty is not successful. After that, we can use. Now, indication for coronary revascularization or CAVG and PCI, percutaneous coronary intervention. Actually, these are used in the patient who have coronary artery disease. Coronary artery disease who have a single, multiple coronary artery disease have a different indications to the PCI and the CAVG. So overall is to improve the survival and relieve the angina obviously and prevent the myocardial infarction to progression and improve the left ventricular function in the ischemic type of cardiomyopathies. So if patient depends time to come. Specific indications: ACS, aortic acute coronary syndrome, ST elevation type of MI. Immediate primary PCI is the preferred strategy if the patient can perform within 120 minutes. So time is very important, whether you use percutaneous intervention, PCI, or there is a CAVG. PCI is preferred over the CAVG in the patient comes within a time, or in the case of acute myocardial infarction or STEMI type of infection. Fibrinolysis followed by routine early PCI. When PCI is not immediately feasible, then after fibrinolysis, fibrinolysis therapy like a streptokinase or urokinase, and once patient is get stabilized, and after stabilization we can plan for the PCI. Non-ST elevation type of MI or unstable angina, there is the early invasive strategy in a high-risk patient, like enzymes level are increased, ECG changes are dynamic, or there is a regular changing in the change in the ECG. Patient have a hypo or hypertension. In these type of patient, we plan for PCI coronary intervention in the form of stenting. So we place a stent, acute myocardial infarction and ST elevation MI, non-ST elevation MI or unstable angina. All these patients have a preferred candidate for the PCI. Depends the timing the patient comes in the emergency. If there is a comes in the 120 minutes, we prefer primary PCI. If patient is not stabilized or comes late, then we plan for fibrinolysis. Then we plan for the PCI, but non-ST elevation MI or unstable angina, the secondary PCI is done after consideration of other parameters also. Sometimes patients have a chronic coronary syndromes. There is a significant left main coronary artery stenosis, LAD, that have more than 60%. Multivessels disease, especially left ventricular dysfunction, ejection fraction is less than 50%. Proximal LAD stenosis is more than 70%. Large area of ischemia. Large area of ischemia is involved more than 10% of the myocardium. And the disabling angina despite optimal medical therapy. Patient is ongoing on the medical therapy from the last 2 months or 3 months. Despite this, patient have a symptoms, plan for PCI or CAVG. If ischemia area is more proximal LAD is involved, or multiple vessel disease along with CHF, ejection fraction get down. So all these conditions we can plan for PCI or CAVG. Some other indications that have a specific for the CAVG or coronary artery bypass grafting, that have by grafting of the coronary artery. Left main disease means left main coronary artery disease, or there is involvement of the left main coronary artery disease along with the heart failure, left ventricular dysfunction, and there is a 100% block of the LAD. These are some indication for the CAVG. Second one is a triple vessels disease with impaired left ventricular function. Means there is all the 3 coronary arteries involved. In that condition, CAVG is preferred over the PCI. Third one, if patient have a diabetes along with 1 or 2 or 3 vessels involvement. In that condition also CAVG is preferred. Why? In diabetes have disease, they have proatherosclerotic. The chances of block of the stent is more in the diabetic patients, so we preferred CABG. Complex coronary artery anatomy that have available to PCI, that also considered for the CABG. Indication for cardiac transplantation. Cardiac transplantation that remains the definitive therapy for the end stage of heart failure. Patient have chronic heart failure in the form of advanced NYHA class 3 to 4 despite optimal medical therapy or other devices. Recurrent hospitalization within a year for the decompensated heart failure. Intractable angina not amenable to the revascularization or CABG or PCI. So these conditions, patient have a advanced stage of the heart failure, not relieved by the optical medical therapy. Patient have used multiple devices, recurrent hospitalization within a year, intractable angina despite optimal medical therapy, or patient is not suited for the PCI or CABG. In that condition, ultimately, if patient have a heart failure, ejection fraction gives less than 30% and symptomatic indication of cardiac transplantation. Some are the specific criteria. Peak volume oxygen less than 40 per kilogram per minute along with beta blockers, or less than 18 ml per kilogram per minute without beta blocker. Severe ischemia, dilated or restricted type of cardiomyopathies, life-threatening arrhythmias also that refractory to the medical therapy or not indication for the candidate for the ICD or ablation therapy. Severe congenital heart disease that not feasible to repair. So all these patients may plan for the cardiac transplantation. It means that patient have a dilated, restrictive or ischemic type of severe type of cardiomyopathy that have heart failure. Contraindications to some cardiac transplantation like active infections at the time of patient have admission, malignancy within a first 5 years, significant irreversible pulmonary hypertension, multi-system organ failure like sepsis, severe non-cardiac comorbidities like chronic kidney disease or the CLD. Because chances of failure is more in these conditions, so we can avoid the cardiac transplantation if patient have a active infection on the chronic like a tuberculosis, or there is at the time of presentation multi-system failure with organ sepsis, malignancy of any kind within a first 5 years, significant irreversible pulmonary hypertension, or there is a CLD or CKD. In these conditions, we avoid the cardiac transplantation. Patient if age of more than 70 years, obesity, BMI is more than 35 to moderate to severe obesity, and poor psychosocial support or non-adherence to consonant, because after cardiac transplantation there is a multiple therapies are required and continuous adherence is required. So there is a cardiac transplantation is doing only the physically along with the psychologically active patient only.